Thank you for joining today's webinar, Methadone in Old Medication with Untapped Potential. My name is Michelle Peavy, and we're here at the University of Washington's Addictions, Drug, and Alcohol Institute. And within ADAI, we're at the Center for Community Engaged Drug Education, Epidemiology, and Research. As always, let's start with a land acknowledgement. I'd like to begin by acknowledging that as we gather today, we are on the ancestral homelands of the indigenous peoples who have lived on these lands since time immemorial. Please join me in expressing our deepest respect and gratitude for our indigenous neighbors. Thank you so much for being here. And as we start our hour together today, please introduce yourselves in the chat with your name and organization. And please type any of your questions, comments, other connections in the chat box throughout our hour today. We love that interaction. And I'll just say I am uncontained with excitement about today's webinar. We were all just sort of catching up before this started. So I'm just going to jump on in. I'll mention that there's an informational report by the same name as this webinar, Methadone and Old Medication with Untapped Potential. And the report is on the ADAI website. And this is an informational brief. It has a lot of information. And today we'll be touching on some of it and trying to bring that information to light. So first, let's start with the very, very basics. What is methadone? Well, methadone is a medication approved by the FDA to treat opioid use disorder. The way that methadone treats opioid use disorder is that it reduces the symptoms of cravings and withdrawal. Methadone is an opioid, so it behaves like other opioids. In that when people take it, it enters the body and locks into our opioid receptors throughout our brains and body. And methadone has some of the same effects as other opioids. A major difference between methadone and other opioids is that methadone is long acting, which simply means it lasts a long time in the body. So people need only to take methadone one time if it's a therapeutic dose in order to stave off the craving and withdrawal symptoms. Whereas other opioids like heroin and fentanyl, people need to administer those opioids several times per day in order to stave off cravings and withdrawal. And with just one dose of methadone per day, it not only curbs cravings and withdrawal, but also allows people to re-engage with other areas of their lives. Methadone really works to treat opioid use disorder. And when I say it works, what I mean is that research shows that when people are taking methadone for opioid use disorder, they're less likely to die. And they're also less likely to take other opioids. So that's actually kind of my definition of methadone. And it's also a medication that treats pain, but we're not talking about that particular application today. Methadone as a medication for opioid use disorder can only be dispensed at federally certified places of service called opioid treatment programs, or OTPs. Opioid treatment programs are highly regulated environments and regulated by a whole bunch of federal, state, and other credentialing bodies. They are full treatment facilities where people not only get their methadone medication, but are treated by a transdisciplinary team of providers, including medical providers, counselors, caseworkers, and others. And many OTP patients need to come in for medication dosing very frequently, like 6 days per week for medication dosing. Okay, so we're going to hear a lot more about methadone and opioid treatment programs today, and you're going to hear about these things from experts, but those are sort of the definitions of methadone and opioid treatment programs. There you go. And given those definitions, or perhaps out of your very own experience, perhaps you've had some questions like, why is methadone sort of separated into these OTPs? Why is it limited there? Or why is this type of treatment so separate from other medical treatment, substance use disorder treatment? Or another question, why do I hear so much about buprenorphine when Michelle just said that methadone is really effective to treat opioid use disorder? So you might have these questions, they're really good questions. And the answers to questions like this is, of course, that it's complicated. It's a complicated set of answers, but much can be explained by history. So history tells us the story of why we have this unique system that's built up around and surrounds methadone. And the info brief itself has a lot of information about history. It's actually like half history, half other stuff. So a lot of details in there about history you're welcome to read. And really what's meant by kind of outlining that history is to really explain why we are where we are today with the current system of methadone and how we have arrived here. So the history of methadone as a treatment more or less starts in the 1960s with the first research studies on methadone to treat opioid use disorder. And those studies, they're so storied as they are, that they were quite successful, as you can imagine. And once it was deemed that this treatment was successful, the treatment itself left the hands of the clinicians and kind of went underneath the federal government and others. And you know that when a treatment leaves the hands of clinicians, sometimes these things go askew. And there are just so many parts of the history and the details that, again, are kind of outlined in the brief. And so many parts that as we were writing it felt, heartbreaking and frustrating, but also triumphant. So I encourage you to read kind of those details of the history in the info brief. But here's one thing I can say for sure. Methadone treatment has always been, throughout history, has always been the most hated, the most reviled, and certainly the most misunderstood of all treatments, possibly in all of medicine and certainly in all of substance use disorder treatment. So this kind of stigma around methadone is really the hardest for the patients who want and need this type of treatment for their opioid use disorder. So it's definitely hardest for the patients, and it also carries over to the people that work within methadone treatment. So you think there's stigma now around medications to treat opioid use disorder? Yeah, there is. But can you imagine the kind of thick skin you needed in the 1970s, 80s, 90s, 2000s to be a patient receiving methadone for your opioid use disorder, and also for the people working within methadone treatment? So in order to advocate for methadone treatment, you had to be willing back in the day, certainly now, but definitely back in the day, to get booed off stage, as I was in 2012, booed off stage for talking about methadone. You had to be willing to fight for the patients, and you really had to be willing, quite frankly, to fight for the right to even exist as a place of treatment that offered methadone as the medication for opioid use disorder. In other words, in Carol Davidson's words, you had to be a rebel with a cause. So you were a rebel with a cause. You were a rebel because methadone was the outlier in treatment and medicine, and in many ways it still is the outlier. But you were and are a rebel with a cause because there's a real cause here. And the cause is to make this treatment more available to patients, and the cause is to educate and reduce stigma. Oops, sorry. Let me just get way ahead of myself. We have some rebels with causes here today. We have lots of guests, but the first two people here today lived the history of methadone treatment and spent their lives advocating for people who take methadone for their opioid use disorder. Two of my own mentors I'll introduce first. So when I first set foot in an OTP in 1999, I never thought methadone treatment was weird or unusual. It was just treatment. And that's all I knew. And my mentors taught me that. And these mentors also taught me that what you do with your ambition and your energy is that you pour it into helping people whose voices are drowned out. And they taught me that a worthy way to spend my life is serving people with opioid use disorder. So I thank you so much for that. I might tear up Thank you, Ron Jackson and Carol Davidson, two of my mentors who are here today to tell us a little bit about what it looked like, what the picture of methadone treatment has been in history. So Ron Jackson is a clinical professor at the University of Washington School of Social Work, where he teaches courses on addiction and its treatment. He spent 33 years as executive director of an OTP, Evergreen Treatment Services, here in Western Washington. And he started in an OTP in 1972. Carol Davidson is a social worker and SUDP and one of the clinical supervisors at Evergreen Treatment Services, an OTP here in Western Washington that serves about 1,400 patients with opioid use disorder. And she has started working in an OTP in 1980. And here's the kicker: Carol Davidson still goes to work every single day serving people with opioid use disorder. So two very committed people who know the history of methadone and OTPs. Ron and Carol could spend hours telling tales about their experiences, but I am limiting them to 5 minutes each to tell us a history, to kind of draw the picture of history. So Ron, you first. Tell us a little bit about history.
Well, thanks for the kind words, Michelle. And the first thing I want to do is congratulate both you and Caleb, Dr. Bannon Green, for the excellent work that you did with this info brief. It's really very excellent, and I appreciate all the hard work that you put into it, and I would recommend it highly to any of the readers. So I'll set the Wayback Machine to 1972 when I first started working in a methadone clinic on the Gulf Coast of Texas, and the methadone industry had been rapidly nationalized by the Nixon administration, which came to power in 1968. And one of its principal planks on its political platform was to get tough on street crime. And there was studies that had shown the high degree of association between street crime and heroin addiction. And then here were these published studies that showed that if you put individuals with opioid use disorder on methadone treatment, it would dramatically reduce criminal behavior, because most of their criminal behavior, if not all of it, was in the service of them getting and using illegal drugs, which cost more than they could afford while working, or whatever the case may be. So it was initiated not necessarily for the rehabilitation of the individuals, but to as a community, as a harm reduction for the community, so that people would offend less, be in jail less, and so forth and so on. But there were a lot of forces that wanted to make sure that, okay, if we're going to use this medicine, which has diversion potential, we want to make sure that we keep it under tight control. So these regulations were promulgated, funding came down from the federal government, but the regulations were, as Michelle alluded to, written by politicians and by law enforcement, not so much by clinicians and patient advocates. And as a result, methadone became in this own silo, not only outside of the rest of addiction medicine, but outside of medicine altogether. And that was one of the problems. The other problem that led to the negative atmosphere about methadone treatment was that these clinics started opening up very quickly. There was a big push to get clinics open as quickly as possible, and not everybody knew what they were doing. There was not the fund of empirical research that talked about programmatic factors that led to better outcomes, or even how you would define outcomes. And so methadone treatment got a bad reputation, and so percolated around it. And the problem, there were a lot of problems associated early on. And as Michelle also alluded to, this is a very much maligned and vilified form of treatment. And despite the fact that there has been this ocean of evidence that shows how it improves the lives, the health and safety of patients, those patients still get discriminated against by the criminal justice system, including drug courts, by child welfare services, by the medical establishment, and even, sad to say, ironically, by other addiction treatment providers, including rehab housing. It's to be a successful methadone patient, and there are millions of, you think about 50 years worth of treatment, there are millions of people whose lives have been elongated, they've led healthy, safe lives, et cetera, as a result of this treatment. And they will never tell you about the fact that they were receiving methadone treatment because of that stigma issue. Okay, so I'm going to move forward a little bit very quickly here to the next milestone that I think is significant. And that's, it's now the 1980s, and the Reagan administration comes to power with the intent of reducing social service costs, the social network, all of that kind of stuff. It took away the idea that if you were poor and had a substance use disorder, that wouldn't qualify you for funded treatment. You had to be poor and have some disability that was either medical and or psychiatric to do that. So funding was always an issue for poor people. And paradoxically, that led to the rise, as Michelle and Caleb described in the info brief, of for-profit methadone programs. And there weren't really great standards of care about all of that. And that led in 1989 to a GAO report that sort of called into question the effectiveness of methadone treatment. In parallel to that, not only was the Reagan administration cutting funding, but treating opioid addicts with some compassion was not exactly on the agenda of a Just Say No president campaign, right? And so I truly believe we were on a pathway to being shut down, if not just defunded, but shut down as a modality. And then along came HIV infection. And the empirical research was that individuals who got into methadone treatment became infected much less robustly with HIV than did people who weren't, who were sharing syringes and the like. And so that really did kind of save the day. The Reagan administration really couldn't shut down methadone clinics in the era of HIV. To try to get some standards of care, the first treatment improvement protocol published by the Substance Abuse Mental Health Services Administration was all about how to do methadone treatment correctly. And that began to change the environment for OTPs. And I'll stop there, but the whole trajectory here has been that methadone treatment in its early days was funded and founded and pushed forward, not out of compassion for the patients, but out of a sense of trying to mitigate community harms.
Oh, Ron, you're like an encyclopedia. Thank you for that. And the statement that sticks out to me is that HIV is what sort of changed their trajectory, which is an interesting way to look at this disease of HIV. Carol, you're gonna draw a patient story for us.
Yes.
Tell us about history.
Sure. And I just want to start with this, that like Michelle said, I've been working in OTPs consistently since 1980. And I've really had the privilege of having been both a clinical supervisor and a provider of treatment for caseloads of patients, of being able to grow up with many of the patients that I've known for years. So I want to share with you a case, and I'm not going to use her real name. I'm going to refer to her as Jane. And Jane entered treatment in the mid 1970s, before I started working at Evergreen Treatment Services. And she was discharged from treatment 39 years later, when she was in her early 80s, when she went on to a skilled nursing facility, where luckily she had a compassionate doctor that was willing to take on the prescribing of her methadone medication from us at that point. And that it was a real feat at that time in 2014 to have to be able to do that. Jane had started she grew up in the South. and then moved to LA and then Seattle when she was in her 20s and 30s. She was 42 when she entered treatment, had a history of heroin use, IV use, which went back to her early 20s. She also had a history of injection Ritalin use, which used to be very popular in the Seattle, Portland kind of Pacific Northwest area at that time, and also had a history of sporadic issues with alcohol overuse. She also had a history of PTSD, which was related to some fairly serious, severe domestic violence issues when she was younger, and had a history of depression. When Jane entered treatment, she stabilized on methadone medication really pretty quickly. All throughout the majority of her treatment for over 30 years, never had a positive for unprescribed opiate use, and reported that her cravings, and she was able to stabilize her opiate use disorder, which had been going on for many years before she entered treatment. A significant thing that happened is that in the late 1990s, she missed a day or two of her dosing coming in for her methadone dispensing. Her counselor knew her very well, was very concerned about her, and knew that that was out of the norm for her. So she contacted her emergency contact when she'd called all the hospitals trying to check to see where she was. She couldn't get a hold of her. She called her daughter. Her adult daughter, went, and she had passed out because she had stopped taking her hypertension medication, and she went into kidney failure. And if she had not made that call, she would have died. So being enrolled in treatment and having a case manager and counselor that was really looking out for her best interests really was critical at that point. She became a dialysis patient due to her kidney failure, and she successfully was able to maintain and stay pretty stable with dialysis from the 90s until she went into nursing home care when she was in her early 80s. And during that period of time, there was a lot of coordination with our medical provider staff, our nurses in our dispensary staff, to help coordinate when health issues would come up with her. I luckily became her counselor kind of I would say it was probably 2000, 2005, something like that. And a lot of our sessions were really focused on her, managing her depression that would come and go. She was being independent was very important to her, and she was able to maintain her own apartment throughout most of her treatment. And her family was very important to her. She had a loving daughter who had a successful work career, and she really had an opportunity to spend a lot of time with her grandchildren. And periodically, a lot of our sessions too were kind of focused on her alcohol use, which could be a problem and was pretty significant because that had a major impact with someone who has kidney disease and is on dialysis. But she was really successful with that. She also worked with we were lucky at that time that we had a psychiatrist on staff that could see people that were not able to get into community mental health for medication management. And so I think the takeaways for Jane's story is that for many of our patients, long-term treatment is really what they're going to need. Once they get to the point that their opiate use disorder is really out of control, and they've been using for a lot of years, like Jane is a good example of that long-term treatment is really what all the research indicates is what is indicated. Luckily, at the clinic, she got support for remaining in treatment, even though she had made a lot of progress with her recovery, but medication was something that she felt that she needed, and we needed to support that. And then the other is just the coordination of care, piece that frequently happens in OTP and how critical that is. And so I think I'll wrap it up with that. Thanks so much.
Oh, wonderful. Thank you so much, Carol. And, here's this patient that had a home, had a kind of a medical home, a place where she felt safe and understood. And, the team responded to that. And also, some of you out there might be thinking about the similarities and differences of patients and people who enter treatment now. Really is, a different landscape. As and I should just reiterate, Carol's also seen the new cohort of people with opioid use disorder coming in. So I cherish you both and thank you immensely for being here today and for all the work that you have done in this space. Thank you so much. Rebels with a cause. Unfortunately, we can't sit around all day because we have a few other things to talk about in this webinar, one of which is racism and opioid treatment programs. And we just heard a little bit about history, American history of methadone, and you can't talk about history in America without talking about racism. So I want to acknowledge that systemic racism has really influenced drug policy and addiction treatment and these systems. And there's a lot to say about the subject. I encourage you to read the info brief, which has a whole section on it, and also read more widely and have more discussions about this with your colleagues. I'm not going to do justice here to this topic. But for today's really brief discussion about systemic racism and OTPs, I'll just say that racism is embedded in the stigma around methadone and the places where people get methadone treatment. So we know that methadone treatment, when they were being first laid down in the 1970s, they were established in poor neighborhoods of color, and poor people and people of color have been routed to methadone treatment. We know this according to data. Buprenorphine, on the other hand, just as a comparator, was seen as an alternative to methadone, and it was developed and marketed as an alternative, and it was targeted to white, well-educated people. And if you look at maps about where do people get methadone and where do people get buprenorphine, you can see that poor people of color are routed to methadone and white educated people are routed to buprenorphine. This is sort of on the national, it might not be your experience, but this is what we can see sort of at the national level. Let's see. So I'll just sort of, again, this is an inadequate discussion of this enormous, important topic, but I'll say that the stereotypes that people have about methadone and the places where people get treated with methadone, that those places are dingy. I've heard that, or dirty, or seedy, or drug infested. Those are all words that people associate with methadone treatment. Those stereotypes and the stigma around it is rooted in racism. And I'm sorry I can't give this topic more time than it deserves. And I hope that we have more complete discussions in the future. In the meantime, I want to alert you to a really incredible series being put on by my colleague at ADAI, Lisa Ray Thomas. It's called Tribal Sovereignty and the Indian Healthcare System. And this discussion is not specifically around OTPs, but it is a small attempt to address our lack of understanding of the unique history and status of federally recognized tribes and their members. It's designed to address our gaps in understanding of the Indian healthcare system, increase our understanding of the history of colonization and the impacts on health outcomes for past and current American Indian and Alaskan Native people, bring to the fore a better understanding of the resilience of American Indian and Alaskan Native communities, among many other things. So I believe that someone can put the registration link for this incredible series in the chat so that we can continue to have these conversations. Okay, but I do want to spend the rest of our time together talking about methadone and opioid treatment programs in the here and now, and also what exciting changes we might see in the future. And to help me do that, I've got a couple of experts here who have also spent their professional lives advocating for and serving people who choose methadone to treat their opioid use disorder. So my friend and colleague, Sarah Chowdhury, is a licensed clinical social worker and program manager at the opioid treatment program in the VA Puget Sound healthcare system. VA is, of course, Veterans Administration. Sarah started her career treating opioid use disorder back in 2001 in the UK with the London Borough of Redbridge. She returned to the United States and worked at Evergreen Treatment Services starting in 2005, and then left ETS to go to the VA in 2008, where she's been ever since. She is also considered such an expert that she serves as the West Coast lead for the National VA ECHO program, sort of a training for, provides national training for other VA providers on opioid use disorder and evidence-based interventions for working with veterans with opioid use disorder. So thank you, Sarah. We also have Jessica Blows, is the Washington State Opioid Treatment Authority and manager of behavioral health clinical supports at the Washington State Healthcare Authority. So again, let me repeat Jessica's title. She's the authority of all opioid treatments across the state. So she brings that kind of leadership to our discussion today. And she's been working in opioid treatment since 2011 in her home state of New York, where she has also served in a variety of clinical and administrative roles. And I can't say enough about the two of you, and I really appreciate you being here and adding to this discussion. So you're in the best place to talk about the here and now, and also how we might move forward. Okay, so I'm just going to kind of open it up to some questions I have, and I'll also be monitoring the chat along with some of my colleagues. Okay, so I'm going to lob this question out to Jessica and Sarah. We've talked a lot about kind of how methadone is sort of in this separate track, kind of seen as separate, and there's history behind that. Here's the question: why do you think methadone treatment continues to remain separate from other types of treatment?
I feel like I have maybe a really easy answer. It's both easy and complicated. And for me, when I think about this separation, I go back to stigma. I mean, you know, I heard somebody say this a couple of weeks ago, and even though I've worked in this field for 20 years now, I really connected with it. And what I heard this individual talk about is how, you know, this is one of the only medical conditions where the person with the medical condition is stigmatized, the diagnosis is stigmatized, and the treatment is stigmatized. I mean, I really can't think of any other condition where stigma is so involved. And I think, Michelle, you said it so perfectly, it's complicated. So when you kind of think of stigma, you think of kind of where opiate treatment programs are located, funding issues, regulations that really are about, you know, about involving the DEA or kind of punishment protocols for ongoing substance use. It's just been treated really differently. And I appreciate Ron just kind of talking about the historical context, because I think it just gives a lot of information about why things have been separated for so long.
Well, to jump into that topic as well, you know, I see a question in the chat, isn't it also government regulation? And you know what? I agree with that. Some of my comments today are about there has always been this exceedingly high level of regulatory authority, and then also administrative burden that gets put on opiate treatment program providers, whether someone wants to open a clinic, operate a clinic. And, you know, I had some of the exact same thoughts echoing other comments earlier. historically, individuals with substance use disorders and opiate use disorder, we've always treated these populations in a more punitive way. Oftentimes, patient populations sometimes are treated as though they cannot be trusted with even their own medications. And thus, the stigma, and I'll even say the discrimination against these patients has resulted in a history of a regulatory and administratively burdensome climate that, again, just makes it really hard to be a provider, hard to be a patient. There also is a long history of also other burdens that opioid treatment programs have to deal with that a lot of other health providers do not. That, NIMBYism, not in my backyardism, having to work with city and county legislative authorities to do community relations planning, to make sure that programs are not being zoned, inappropriately. There's oftentimes barriers to expansion of opiate treatment where, they're not being treated the same way that other healthcare entities have been treated. I know parity is a topic that has come up in this discussion, but you're right. This is opiate treatment programs are beautiful because they're a blend of, physical healthcare and behavioral healthcare, and our whole system is trying to work towards integrated treatment. But again, we're not treating these settings oftentimes with parity to other types of healthcare settings. And I do think a lot of that just comes back to this ongoing theme of just stigma and discrimination against the patients that they're serving.
Well, so this sort of tacks on this next question. So buprenorphine, this is a medication that was developed to treat opioid use disorder and really available in 2002. So really, really recently compared to methadone, which was available in the early 70s. But in 20 years, we've made all kinds of inroads in terms of accessibility, in terms of changing people's hearts and minds about medications to treat opioid use disorder. I mean, if I knew someone, many of us could refer people to low barrier bupe clinics and they could receive medication, promptly. And so, and it's integrated into all these different sites. So why do you think buprenorphine has been able to make such massive gains in 20 years, whereas the treatment model for methadone has remained pretty unchanged since the 1970s?
I'll start with this one. I agree, right? We're always talking about access to low barrier buprenorphine, but where's the discussion about what is low barrier methadone access going to look like in the future? Again, we've been talking about the stigma and discrimination that's kind of pervasive through the history of regulations. I also feel like, methadone is in the unfortunate position of being almost in a catch-22 because it has been so siloed. There's oftentimes misinformation, just a lack of knowledge, the idea that it's like other and separate from other forms of treatment. And because it is siloed, it perpetuates that lack of information because oftentimes other healthcare providers may not necessarily, really be that familiar with methadone and what is allowable. Again, parity, I think, is a huge issue with the topic of physical healthcare. And then really just even a basic understanding for patients and the general public that medications to treat opiate use disorder are like the first line approach to treatment for opiate use disorder, and that methadone is part of that. And methadone is and should be, a treatment that is offered as an option to all individuals who are struggling with opiate use disorder. And having the ability for patients to have that truly informed decision making. I think a lot of times, buprenorphine has been offered because that's the only option that might be getting offered to an individual at that time. And it would require healthcare providers to know better how to make referrals to opiate treatment programs for patients who would require methadone, or to do care coordination better with providers because their patients might be on methadone. And I think it just also really highlights the continued need that's out there for more education, information on just methadone in general, and then also medications to treat opiate use disorder in general.
Can I add a couple? Oh, yeah, no, I can't interrupt Ron. Ron, you go first.
Oh, no. Oh, Sarah, jeez. So there are two sad truths about medications for the use of opioid, for the treatment of opioid use disorder. And the first one is we can't tell which medicine is going to be most effective for a particular individual who has opioid use disorder. That's number one. So we don't know whether Ron would be better off on methadone or buprenorphine, or for that matter, extended release naltrexone. The second issue is how long does Ron have to be on this medicine? And there's scant evidence that suggests a finite period of time. It's like the use of medicines for other chronic medical disorders. No, the clinicians can't predict how long Ron's going to have to be on this medicine, which is very vexing if that medicine is as stigmatized as it is, if the process of getting that medication is as complicated as it is, and so forth. So that's my 2 cents about it.
I was going to just add a couple things. I think maybe just a first kind of surface level thing is that, I mean, buprenorphine and methadone, I mean, what the, one's an agonist, one's a partial agonist. So I think there's a perception that one is safer than the other. So I think that that's impacted things. But again, I kind of see that as a surface level. The social worker in me and the critical thinker in me also just wants to acknowledge something that we've already kind of been talking about, which is the fact that I don't think it's accidental that access to buprenorphine, which is more readily available to to white people or people that have the economic means, also has the least restriction. Whereas the medication like methadone, that is really for, it's more marginalized groups accessing it, has more restrictions and has, and hasn't really changed much over the years. So I just want to throw out there that for me, like part of the reason things haven't changed is because of the populations that are being served.
Thank you. This could be such a rich discussion. I do want, though, to get into recent history, which is the last 2 years. And, COVID impacted all of healthcare. It impacted OTPs and methadone in a major way. Sarah, tell us what it was like when COVID hit and what that meant for opioid treatment programs and people getting methadone for their OUD.
Well, I could easily talk about this for a very long time. I became program manager for this clinic in January 2020. And I think it was maybe 2 weeks later that COVID was kind of showing its face in the Seattle area. And I'll tell a little story. I remember being at work. So this is like February, and a primary care doctor calls me and he says, I just talked to one of your veterans that's on methadone. He's at home. I think he has COVID. He has COVID symptoms. I've told him he's got to stay home for 2 weeks. He needs his methadone. What should he do? And I was like, I have no freaking idea because just a reminder that for methadone treatment, patients have to come into the clinic. Often their doses are observed. And for this particular veteran, he was coming in 6 days a week for observed dosing because he was using non-prescribed substances, which in kind of the OTP world meant that that he had to come in every day for dosing per our policies and regulations. So I guess my point in sharing that story is that's kind of how it went in the beginning. Jessica knows this very well because Seattle and New York, we were kind of the first areas to deal with COVID. We were first OTPs. Seattle and Tacoma were the first VA OTPs to kind of manage this. And I've heard, in fact, Jessica, I think I even heard you a couple days ago on another call say this, but we said it a lot where we were definitely building the airplane as you fly it. And so, for example, with this particular veteran, I know our medical director said, oh, wait, I don't have any patients scheduled for the next 2 hours. I'm going to go take his medication. I'm going to go take it to his house. And that was our first methadone home delivery. And we ended up doing home deliveries throughout maybe the first year of the pandemic. We've had to do that less so, but that, I mean, going out and delivering medication to a veteran's home was just like this whole, this was just like revolutionary, and was never, you know, it's always been, if you need us, we're here, but you've got to come to us. We are not coming to you. If you really want this treatment, you're going to be here. But imagine, you know, somebody's telling you, okay, you're my brother's type 1 diabetic. Imagine, you know, somebody saying to him, hey, look, I'm sorry, you got to stay at home, but if you need your insulin, I'm sorry. So I think that's probably one of the biggest changes for us, was really figuring out how to ensure veterans got access to their medications. The thing too with access was, if our doctor or our staff are going to deliver medication to somebody's house who potentially has COVID, yeah, great, we want to get that person their medication, but how do we keep our staff safe? What do we do if we're delivering medication to somebody that has COVID? I don't want my staff getting COVID. So we kind of just made up some protocols. We consulted with Jessica, who is phenomenal, by the way, and we were really lucky to have Dr. Saxon, who many of you know, and just kind of the support nationally to do some innovative things. I'll just say another thing, because I think this might come up too. One thing that was a really big deal for opioid treatment programs was not having patients come in every day for observed dosing. And this, you know, you're in this situation where you're having to weigh out risk because kind of what's happened in opioid treatment programs is a message that if you are on methadone, but you are using amphetamines, if you're using amphetamines, then we have you come in every day and we observe you taking your methadone because of your amphetamine use. I think there's been this message that maybe somehow you're not safe taking your methadone or having these methadone doses at home. So here we were with, you know, 3/4 of our veteran population kind of being seen and meeting the at-risk criteria for COVID that the CDC laid out. And suddenly you're like, okay, what's riskier? So we ended up giving what we call carry doses. So that's doses where medication that patients take home with them. And we, for some, we gave them a week's supply. I think in the beginnings, we were giving most veterans at least a week's supply, and then up to a 2-week supply, and so on. So yeah, so I just wanted to just acknowledge what a big change this was for opioid treatment programs.
Absolutely. And I think, you know, people are waiting with bated breath about these take-home relaxation policies that have been put in place. Jessica, can you look into the crystal ball about, you know, what about these new policies and what's the staying power?
Definitely. I think this is a topic that really is on everybody's mind. I am very fortunate. Currently, I am the president of all of the state opioid treatment authorities. So I've been in lots of different discussions at the national level with federal partners. Again, I know you mentioned to the audience, Michelle, you know, opioid treatment programs are just regulated by a huge number of entities. So an important part of the discussion for the future is also acknowledging there are some changes that happened that are a result of SAMHSA, Substance Abuse and Mental Health Services Administration, branch of government, making changes, some changes as a result of changes in DEA specific policies. Some things have been allowed to happen because of CMS billing changes. Other things have happened because of state changes. So for the most part, I guess I would like to deliver a message to the audience that Washington State, any regulations that are within the state's authority, the state has a real vested interest in continuing flexibilities that the state would have the authority to allow. Also, SAMHSA, a federal agency, has released feedback to states to allow for states to opt in at the end of the public health emergency to continue the take-home flexibilities. They have released a bit additional guidance that can be passed on to opiate treatment programs as well to help better determine who, a patient should be considered stable versus unstable, but it would still allow up to 14 days of take homes for an individual who's unstable and up to 28 days of take homes for folks who are stable. So our state is going to be opting into that. And then again, the overall message from SAMHSA has been, this is something that can be done until they can determine if that agency is able to change the law, the federal law itself, or if there needs to be potentially like an act of Congress to change some of the regulations in the CFR. But again, that to me is a really good sign that the federal government has kind of given out feelers. They want to continue some of the flexibilities. We've also, Sarah highlighted the discussion. One of the flexibilities is around the opportunity to deliver, medications for methadone, specifically to patients' homes, to set up, a secondary dosing site if needed. Certain things with telehealth prescribing of medications for both methadone and buprenorphine. A lot of those are within the DEA's regulatory authority. And while they have not released as concrete plans publicly yet, we do know that the DEA is trying to also figure out, what things they could potentially change to allow flexibilities to continue if they need to do a temporary act of some kind that would go into effect at the end of the PHE until they can figure out a permanent regulatory solution. So again, our state very much supports this. I can say that nationwide, SOTAs are in almost, that's the State Opioid Treatment Authority's total agreement that the flexibilities have been really good. I think we've also had opportunities in different states to collect information to see if there were negative outcomes in relation to providing more take homes, again, having more access to patient medication, more services with teleprescribing. And the reality is the outcomes have been well. And in a lot of instances, patient retention has even increased. We have not seen substantial increases in patient overdose deaths, negative outcomes, things like diversion of medication. So really, nothing about COVID has been good. But if there's any small sliver of a silver line, it's that this has become a real-time experiment for changing some of these regulations. And I think the results kind of speak for themselves. And I would like to think our federal partners are moving in a direction of more possible changes. And I think there'll be probably a couple more questions where I could comment on that too.
Yeah, so there's the keeping of the flexibilities. That's one thing. And then, aim big. Like, what do you hope to see big picture? Like, what kinds of changes do you envision?
Sure. I'd like to bring up with the audience, several months ago, the Office of National Drug Control Policy had a forum with the national academies to talk about the future of methadone regulation. And anyone who's interested in this topic, I highly encourage you to seek it out. It is about 15 hours of content and it's all online. You couldn't break it up, treat it like a podcast. But it was really riveting because honestly, the discussions that were being had in this context are everything from how to help opiate treatment programs have rules and flexibilities be allowed to them in the future that could promote, again, better patient access to care, better patient retention, allowing more flexibility for medical providers at opioid treatment programs to make decisions about patient care that are, you know, already existing in other physical health settings. Then there are also a plethora of ideas also about, you know, really truly game-changing possibilities should the nation allow methadone access to be allowed through prescriptions. Should we have pharmacy-based dispensing of methadone in addition to opiate treatment programs? Should we have even more telehealth flexibilities? You know, during COVID and the recent pandemic, you know, opiate treatment programs are not allowed to start and induce people onto medications via telehealth. But, you know, should that be something that could be and should be allowable in certain situations in the future at the discretion of an opiate treatment program medical director? So again, I think these things are all really exciting. And, you know, on behalf of the state of Washington, I can't speak on every single piece, but, you know, the state is supportive of an evolution in treatment, as long as, again, there are opportunities for also opiate treatment programs, because I think it's very important that opiate treatment programs also be allowed to evolve beyond the current structure. And in reality, I think there are probably common sense safety parameters that could be put in place that would allow changes in both opiate treatment program and non-opiate treatment program settings that would still promote patient health, safety, and wellness.
Do you want to say anything about the mobile medication units?
Mobile medication units? Sure. I think another thing too, the federal government has opened up the ability for opiate treatment programs to have mobile medication units, which is literally a mini OTP on wheels. It's a form, it can be like almost like a Winnebago type of van, kind of similar to mobile medical clinics or mobile vision or dental clinics. You know, in a state as geographically vast as Washington state, it could really be a helpful way to expand the footprint of opiate treatment programs that are, you know, it's a physical fixed site. There are some barriers. Individuals have to travel. You know, we have Medicaid data that shows some people are traveling 2-3 hours a day just to get a daily treatment. If there is a way to have a mobile site that could go and, you know, park somewhere an hour and a half outside of the OTP, that could really, again, expand the access for methadone to individuals. It'd be really helpful for rural populations, places in central and eastern Washington where we don't have access. Also in urban settings, you know, there are houseless individuals, folks who still have barriers to transportation access. It could still help literally bring treatment to people where they're at, meeting people where they're at. Also could be a great, unique opportunity for government to government relationships. You know, we're very proud to have the highest number of tribally owned and operated OTPs of any state in the country right here in Washington. And again, there could be great opportunities for that. And I see that Ron has raised his hand.
Yeah,
Well, yeah.
Based on my experience with operating a mobile methadone van since the late 1990s, the rate limiting factor here are the political influences of the local jurisdictions. You can have the greatest van, you can have the greatest crew, you can have the greatest need, but if they won't let you park it anywhere, you got no van.
Right, we forget that there was mobile methadone years ago. Carol.
Well, and as far as being creative with during COVID, we have a mobile methadone van, but during the pandemic, we have utilized that to help address our patients that are COVID positive, that are not able, don't have places to go with take homes, and screening people who have symptoms and having them dose kind of in a safer area that's more outdoors behind our building really came in handy. And
Fantastic.
we didn't have one, as far as I know, we haven't had one patient or one staff that had, if they became COVID positive, it wasn't through an exposure at the clinic site.
Excellent. Wow. Well, we could have talked for another hour. I only got through about, a portion of my questions, but to all of you that were guests today and audience members, I'm so appreciative. Just some announcements here about how to find us and upcoming trainings, transforming our communities, where I get psilocybin for my opioid use disorder. So that's an ever popular topic. The tribal sovereignty series I talked about, and we're having a trauma conference in the fall. So we'll let you go, but thank you so much for all the work that you do on the panel, and then our larger audience as well, who's all out there doing the work. So thank you and have a wonderful afternoon. Thanks so much.